Hello, and welcome to the Trauma-Informed Care in the Long-Term Care Organization video training series. The topic for this presentation is care plan development. My name is Paige Hector. I am a social worker of almost 30 years focused on post-acute and long-term care settings with lots of interest, including, of course, trauma-informed care, process improvement, and clinical operations for the interdisciplinary team. I do write 2 columns for well-known publications, and I'm involved in several national work groups and committees. My bio will be available at the end of this presentation. Here is the list of the video series, and as you can see, we are down at number 7, care plan development. And in our discussion today, we're going to be covering person-centered care and a strengths approach, needs statements, care plan goals, interventions, and then specifically trauma-informed care plan interventions. I'd like to start off with an invitation. I would like you to take a moment and write down a list of 5 things that if you were to come live with me, that you would want me to know about you. If you were going to come live with me, what would you want me to know about you? It's really important. So take a moment and jot a few of those things down. I've done this a few times in different workshops and conferences, and it's absolutely amazing to me the things that people write down, things that are important to them about themselves and their daily life and how they want to be cared for. And then I want you to think about the care plans in your facility. Do they reflect these types of things? When you think about the care plans, we tend to focus on quality of care, which is wonderful. We need quality of care. But a lot of times with this exercise, what people write down are things that really reflect quality of life, the things that bring them joy and pleasure and comfort and safety. So this is a way that we're going to be kind of switching the way that we think about care plans and really inviting more of the trauma-informed care and person-centered care perspective into our work. So really, what is person-centered care? Again, if I asked each of you to write down a definition or just thoughts about really what is it, I think that we all kind of have an idea of what it is and how we might go about doing it. But I find it helpful to take a look at the actual regulation, person-centered care, which is covered in FTAG 675. Just a few things that I want to point out here. There's actually some really great information in the guidance to surveyors for this particular regulation. The way that it's defined is that person-centered care is a focus on the resident as the locus of control, supporting the individual to make their own choices and having control over their daily lives. That makes sense, right? When you think about, well, how then do we go about doing that? So we kind of get that that's the definition, generally speaking, but how do we make that come to life? Emphasis on self-worth and self-esteem, that the resident has choice in the decisions, that the staff is supposed to support the resident, helping identify to them what's important to them, enhancing their sense of satisfaction with themselves, the environment, the care that they've received, their desired goals. There's just so much that goes into the concept of person-centered care. So my purpose with this session is to give you some ideas and ways to go about making person-centered care and trauma-informed care come alive. Here's a few discussion prompts. Who is this person? And the first question is so important to me because as a social worker, you know, my training and experience is all very much focused around the individual within their system of care, and whether that's the nursing home, the community, their family they live in, and all the people and interactions that they have. So who is this person? Not the disease, not the problem list, but who specifically is this person? What's important to them? What are their values and beliefs, and what brings them comfort, a sense of safety, or a sense of joy? What are some things that instill a sense of sadness? Now, I want you to think about your screening and assessment tools. Are any of these types of questions on any of those tools that any of the disciplines in your facility happen to use? So just because we ask these questions, and of course you're going to recognize these obviously from the MDS, what to wear, do they like a bath or shower, morning or night, what do they like to eat, favorite music, TV shows, and do they want to go outside when the weather is nice or use the phone in private? And absolutely, all of these things truly are important. These are important to me. And if I come to live in a nursing home, I do want my wishes to be upheld and respected. But the thing is, just because we ask these questions, it doesn't automatically make person-centered care alive. So we have to be able to ask the questions and do the screening and assessment, and then do something with the care plan, which is our topic today, to make it come alive, to help staff to know exactly what to do and not to do for each individual. So you might be familiar with Louise Aronson, quite well-known physician, and she wrote a fabulous book called Elderhood. There's one particular excerpt I'd like to share with you that really struck me. She wrote, "If we feel the need to use the catchphrases like patient-centered care, then what exactly is medicine? Shouldn't patients always be the focus of healthcare? Something is missing in the current system and its underlying paradigm, something important." So I just really loved how she summarized, and she uses the term patient-centered care, which to me I would say person-centered care. But if we have to use that kind of a phrase, then is there something that we are doing that we can be improving upon? And I think the answer is yes. We are all very familiar with the medical model. It's something that's very familiar to healthcare professionals. We have a problem or a diagnosis, we have symptoms and diagnoses and a treatment plan. There's nothing inherently wrong with this. This is a traditional medical model. So trauma-informed care and person-centered care, they simply build into the medical model. We add into that framework person-centered care of what's really important to that person, what are their strengths, and I'll talk a lot about strengths assessment in just a couple of minutes. So it's a blending of the two. It's a blending. Trauma-informed care is like the foundation, and then we blend into that person-centered and trauma-informed care. So it's not about taking away the medical model or saying it's not okay. We're simply adding to and blending it. Care plans should be strengths-based and emphasize resilience. Alternatively, our traditional medical model that we're all very familiar with tends to emphasize deficits. I mean, just take a look at, for example, a history and physical or your orders upon admission, the paperwork that the medical provider typically completes, the staff completes as well. We tend to emphasize deficits, the problems and the symptoms and diagnoses. So again, we're adding to it, we are expanding on it, and including elements of resilience. So there's lots of definitions of resilience, and the one that I particularly like, by the American Psychological Association, it says that resilience is adapting well in the face of adversity, trauma, tragedy, threats, or significant sources of stress. At this time in our society and our culture, we're coming through or at the end of, dare I say, end of the pandemic. Resilience has become such an important part of who we are as we seek to grow from this experience. We seek to heal and to recover together. So I think it's especially important that we focus on resilience with our residents and patients, and quite frankly, with one another. You might be familiar with the work of Joan Devine from the Pioneer Network. She's a wonderful speaker. She wrote a great piece about person-centered care planning, and she said that anyone should be able to read it without seeing the resident's name and know whose plan it is. And I thought that is just so perfect, that a truly individualized person-centered care plan would be able to convey the essence of who that individual is, what's important to them, what their goals are, and then the specific nuances about that individual. A person-centered care plan does not define people by their disabilities or problems. So as we go through the nuances of the care plan development, I'll bring that more to life for you. And that we help identify people's abilities, how we as staff can support ensuring not just their quality of care, but their quality of life. It's both of them together. Here's a simple example. So if we were in a room together, I would ask people to call out, so if you had a backache or a headache or just pain in general, what might you do for it? And I'm sure that there might be some overlap and some similarities, but truly a person-centered care plan would specify, what do you specifically do when you have a backache? Now, if I were to take that same, your goals and what works for you, and I just put it on everyone's care plan, that is not person-centered or individualized care. So I want you to start thinking about the care plans that we use and perhaps whatever software that you use, and it has the drop-down menus where you can pick and choose the different interventions. While I understand the rationale for using those drop-down menus, and that certainly makes our work easier, but we also still have to keep in mind, how do we individualize these care plans for people that make it unique to them? So if I were to take that one care plan and kind of just put it across the board for everyone who has backache or back pain, I am not, that's not individualized or person-centered. So I started thinking about, well, how is it we can honor person-centered care for medical diagnoses or unmet needs, diabetes and incontinence and fall risks and terminal illness and hypertension? So are there nuances that are unique to this particular resident that as they live with and manage, for example, incontinence, what are some things that are really important to them? And this is where we bring in elements of person-centered and also trauma-informed care. There's a wonderful video. This is not even 2 minutes long, and I would love to recommend to staff to use this video in your training as you do more with person-centered care and talking with staff about that. The person needs to come first. So what do I mean by that? As you can see here, in this video, it does just a really great, very simple job. The person plus the disability becomes a person with a disability, but the person is first, versus the disability and then the person, what we then have as a disabled person. So for example, a person with diabetes is a person living with diabetes. It's not a diabetic, because that becomes the qualifier, as though the only thing that's important about the person is the fact that they have diabetes. Another example where I see this so prevalent is with people living with dementia. We tend to say, well, they are demented, or it's a demented resident. Person-centered care turns that around. The person is always first. So a person is living with dementia. They are not demented. They are a breathing, living person living with dementia. So a strengths approach. This is a foundational aspect of person-centered care and certainly trauma-informed care. So a strengths approach, simply put, is the ability to cope with challenges. So you feel elements of resilience in there, adapting well and overcoming adversity. On these next slides, I'm going to give you lots of prompts or questions to consider weaving into your current screening tools and assessments, your interactions with residents at any point in time. I don't recommend that you make a huge form and ask all of these questions all at once, but they're ideas for you to go about incorporating this type of language and communication with residents to really learn what are their strengths, what's important to them. So this particular list of questions comes, as you see the source there, the National Conversation Project, and it says, describe a time when you lived through a period of uncertainty. Was there a silver lining in the disruption? How have you had a chance to get creative to make do? How did you do that? These questions here, as I think about the pandemic and the crises and all of the stress and strain that we've been through with that and continue to experience for a long time, these are wonderful questions that help us to learn about a person and what other times in their life have they overcome stress or chaos or crisis, and how can we bring those skills and strengths into their current experience. Another list of questions is just ask people, what do you consider your strengths? And when I do this video or when I do this presentation live with people, it's so fun to hear people call out what they consider their strengths. You know, what makes a good day for you? What are things that you do because you really want to, not because you have to or you should do them? What do you do well? What gives you confidence? And what makes you feel good about yourself? So these are the kinds of questions that help us to learn more about residents and craft their care in such a way that really does honor them individually. I do want to mention spiritual care. A couple quotations here from this particular resource is that each person should be provided the opportunity to describe what is significant to them and how they experience it. As human beings, we tend to want to make meaning about everything that we go through, especially adversity. We want to understand the whys and how did it affect us and what's the meaning for in our lives. So when we talk about spiritual care, I want to make it very clear that this is not religious by any stretch. It can be for some people, and that's fine, but I want us to broaden the idea of spiritual care into something that's more about the making of meaning. How do we find meaning in what we're experiencing in our life? This is a very important component of every person's overall well-being. And again, it's not tied to any specific religion or practice or culture. It's just how we find meaning. This is a wonderful tool, and I think it's something that whether it's the social work staff in your facility or the activity staff, or perhaps you have a chaplain on board or a nursing staff, but these questions can really be used at any time. So the FICA is a spiritual history tool. So faith and belief is the F. And there's some questions there. Do you consider yourself spiritual or religious? So we're trying to make that broad enough. Do you have beliefs that help you cope with stress, difficult times, and what gives your life meaning? So then it goes on to importance, about what importance does spirituality have in your life? How has it influenced how you take care of yourself and your health? And then community. This is so important, especially now when our sense of community, in terms of the pandemic and how isolated we've all been, reestablishing that connection and community is really so important as we begin to recover and heal. And then the A is address in care. How would you like me to address these issues in your health care? In other words, I learned these things about you that are important, that give your life meaning. How can we help those come alive while you're here with us, whether it's a short-term stay or perhaps for long-term care? Another simple question I just really like is, what would you do with a magic wand? You know, I actually have a magic wand right here in my office. I just keep as a reminder to invite a sense of playfulness sometime, a sense of creativity, and permission to think about, to dream about, really, if I did have it, what would I do with it? Now, we don't want to give people, you know, a hope that we can just fix everything that's not going well for them or that they're in distress about. But I think when we can invite a question like that, because I'm always looking for that gem, that even if I can't make the magic come alive, what they really are longing for, there might be one little part of it that we can, or a modified version of it. Another lovely question is this one. What is most important to you right now? In this moment, what's most important? And then again, here's another one that shifts from the way that we were thinking about things to where we could eventually get to. It's moving from what's the matter with the individual to what matters to that person. I love that play on words. This really supports a trauma-informed care perspective. If you remember from past videos when we were talking about the shifting or the lens of what's wrong with a person to what has happened in their life, this is that same kind of flavor, from what's the matter, which is really problem-oriented, deficit-based, to what matters. And then, well, what do we do? So we have examples of strengths and resilience for an individual. This is just a list of some that I came up with, that there are so many strengths that even in an individual who is, for whatever reason, maybe an advanced cognitive status or perhaps some other medical issue, maybe they're no longer responsive or communicative, but they still have strengths. Everyone does. So there's so many different strengths. So I want us to broaden how we think about strengths. Here's an example. This is a care plan intervention. This is a care plan goal that a colleague of mine wrote years ago, and I've always kept this as an example because it was so perfectly written. The resident will maintain assertiveness in reporting issues with his computer, so he may continue to effectively communicate via the internet, email, throughout the next quarter. When I look at this, it just really speaks to me of so many different needs, basic universal human needs, which I talked about in the video before about nonviolent communication and how we all have universal human needs. So in this example, this individual, to me, his needs for connection, belonging, stability, contribution, purpose, to be heard and understood, and empowerment. Because when we're saying, well, maintain assertiveness, that's the universal need for empowerment. So this was a lovely example that really spoke to me on many different levels. When we're talking about care plans, I want to just kind of orient us where they are in the whole resident assessment instrument, the RAI process. So we have an assessment. So the comprehensive assessment is first. Then we go to the care plan. We have to implement the care plan by qualified persons, meaning people that have been trained and know how to implement it. We have to revise it when necessary. And then we actually have to provide it. So the provision is actually carrying it out. So I, over the years, have come back to this sequence over and over and over. It's important to realize that we cannot proceed to an assessment. We cannot proceed to the care plan until the assessment is completed. So too often, we are, I think, so rushed and so stressed about all the duties that we have and all the things that are happening every day. We tend to rush through this process and we jump right into problem solving and putting a care plan together until we've really properly assessed the issue or figured out what is the unmet need that we're trying to address in the care plan. I talked about trauma screening and assessment in one of the other videos, so this is just a quick summary slide, reminding us that assessment is not a thing. It's not like a tool, it's not a form, it's not a single conversation. It's a process. Truly, the idea of learning about an individual, what's important to them and their strengths and their unmet needs, it's accumulating input and talking with people and talking with staff. It's an ongoing process. So I would love to see us have that type of framework in terms of screening and assessment, and then developing and redeveloping and revising the care plan as we learn more and more about the residents in our communities. So, groundwork here. Really, what is a care plan? Well, the care plan itself is a formal document that states what we're basically going to be doing. The qualities that it needs to have is that it should be person-centered, trauma-informed, strengths-based, interdisciplinary, and that it addresses needs, goals, and interventions. So I'm going to go over those individually in just a moment. But ultimately, the care plan should focus on maintaining or even improving one's function, health, and well-being. So it's at least maintaining when we can, improving when we can, preventing decline when we can. So there's a lot of different ways to go about this. The main care plan sections I want to talk about are a needs statement, the goal, and interventions. So the needs statement, and some of you may call it a focus statement or a preference. Basically, this is the very crucial part of the care plan that tells us what essential quality is desirable, needed, or wanted. Okay, I'll talk more about need statements in just a moment. And the goal is person-centered, emphasizing quality of life or quality of care. Interventions are the things that the staff will do to help the individual meet the goal to eventually address the unmet need. Now, there's a couple of, I call these expanded care plan components. It's very helpful, I think. I always kind of approach care plans with the idea that they're a working document. So many years ago, we didn't have electronic medical records, and I just loved delving into a care plan, an actual physical document where I could see where staff had, highlighted things or crossed things out, and I could see the critical thinking that's evidenced in the care plan as they tried this and it worked or didn't work, and they tried this, and you could kind of see the sequence in the development of the care plan. So we need to still capture some of the essence of that. So when I say ineffective interventions here, it's basically anything that the staff has tried that does not work. So if we've attempted education or explanation or redirection and those things are not working, go ahead and put those on the care plan. Now the strengths. We can list those strengths in the care plan. There's different ways to go about this. So I don't want to make it seem like there's one formula or one style of a care plan. It's really individualized for you all. How do you do care plans in your community? Ideally, the strengths are woven in, and they would be reflected in the goals. They would be reflected in the interventions. So I'm going to give you lots of examples here coming up. When it comes to care planning sensitive content, and so we're talking about trauma-informed care, and so in the course of screening for trauma or talking with people, we definitely learn things about people that are very sensitive or vulnerable or very private. So when we put things in the medical record, whether it's a care plan or general documentation, be very attuned to what we include and then how much of the what. In other words, is it totally necessary that I share the entire story, or should I really just be focusing on how that story affects the person here and now? So just be aware of that, and how do we very best uphold confidentiality for people? I'm thinking we're ready for a change here. So I created this slide with the idea of a different perspective on care plans. In the essence of time and efficiency, we tend to resort to the drop-down menus, and I totally understand that. But I wonder if each of you could think for a moment, does your care plan software really meet the needs of your residents? Or do you find yourself wanting or longing for other options or the ability to modify those drop-down menus and the options available to you? And I think some software allows people to do that. And I've known that some programs are a bit more challenging to do that with. So the style of care planning that I'm talking about here, I think is definitely more towards the narrative or writing style and a little bit less reliance on those drop-down menus. So the need statement. The need statement is very intentional, the word need, and it's being used instead of the more traditional care plan model that tends to say problem statement, which really lands us squarely in the deficit category. So a person-centered trauma-informed care plan really is going to emphasize more strengths-based. A trauma-informed person-centered care plan emphasizes strengths and not deficits, and the need statement, a really well-written need statement actually should be quite long. It should have a lot of information in there that I talk about painting a picture a lot. When I talk about documentation, it's what are all the nuances I need to know about this individual in terms of the care plan, and what is the unmet need that we're trying to address in this particular care plan. So here's a list of all the different things that we can consider including in a comprehensive needs statement in the care plan. So since we are focusing here on trauma-informed care, this list really speaks to that topic. So obviously, if you're doing some kind of a trauma screening, in one of the previous videos, I talked about the primary care PTSD-5. So whenever we do screenings, maybe the PHQ-9 screenings that you do in the MDS or other screening tools that you might use in your community, talking about unmet and met needs. Now that goes back to the video on the nonviolent communication, identifying what are the unmet needs for an individual. Perhaps they have a need for safety or security or trust or contribution. Cognitive issues that impact well-being if they have traumatic brain injury, if they're living with dementia or a serious mental illness. Include elements of a capacity assessment. Now, some of this we might be pulling in from other disciplines, perhaps the medical provider or someone else has done a capacity assessment, but the needs statement really should be comprehensive and reflect, if not all of this, at least a good part of it. So you'll go on here and see, let me just skim down here, life experiences that might be contributing to the distress or delayed trauma reactions, biological stress response. So if a person tends to go into what we would say is a fight mode, perhaps they become angry or defensive, that information would be good to know. So rather than a care plan, traditional might say argumentative or verbally aggressive, but it doesn't give me the context of what's going on and all the stuff that I need to know that helps me to understand why we're indicating that as an issue to be addressed in the care plan. So all of these things here can be included. And while the care plan should be detailed and comprehensive, I don't advise rewriting a bunch of stuff. So it's not a matter of going through and rewriting the entire trauma screening or anything. It's about bringing in the relevant parts. So for example, you might give an overview of over the past year, the PHQ-9 scores have been, and then you list them. And then you indicate how that might have changed over time, rather than just focusing on one screening assessment or one point in time. The other thing you can consider doing when you write your needs statement is rather than rewrite a bunch of stuff, you might say reference the biopsychosocial assessment and put the date in there. So I would know as the reader, oh, let me go take a look at the social work notes and pull in that document. Or perhaps you had a mental health consultation. You put that reference in the needs statement in the care plan so it's comprehensive, so there's evidence that it's interdisciplinary, comprehensive, strengths-based, trauma-informed, and person-centered. Again, this is just detailing what I mentioned a moment ago. Only include what you are trying or what you know already works. So a lot of times we'll read a care plan and it's kind of like this regurgitation of all of these possible things that staff can be doing. And to me, when I read these care plans, it's like, oh, there's the drop-down menu, and they just click, 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 because they all sound good. Let's just put them all in there. And then what we have is really a document that's more a paperwork compliance document rather than a useful person-centered tool. So for example, if you have tried to redirect or educate or remind or explaining the risks and benefits, if you've tried those options and the individual continues to decline or they don't have the ability, perhaps because of living with dementia or another cognitive impairment, to retain that information, don't continue to put those as interventions on the care plan. You would instead, you could say something like this: educated many times, unable to retain information, or reminders have been found to annoy the residents and not improve the well-being. So we're acknowledging that we've tried these things, because to me, this is the way I always tell staff, take credit for what you do, because I absolutely believe that staff does so much more than they get credit for, and the documentation is one of the places that you can do that. Okay, so let's talk about goals. One of the most important things about goals is that there are no social work activity, nursing, dietary, or therapy goals. There are absolutely no goals. The only goals there are resident goals. They're all about the resident. When the goal is accomplished, the resident's quality of life will be improved, and that's how I know if it's a goal, because it's something that affects the individual's well-being, their quality of life. A goal, you're probably familiar with the SMART acronym for developing goals. So the goal should be specific, be very clear what should take place when the goal is met. So what would I be seeing or hearing that the resident would be doing? They're measurable. How much, how many, how will we know when it's accomplished? They're attainable. In other words, that they're something that the resident can achieve within their current abilities and their current strengths. They're realistic and relevant, that it's worthwhile, it's relevant to the individual, that it actually impacts them in a way that they are in agreement with, and that it's timely. So we typically look at care plans most of the time on a quarterly basis, and then once in a while, like if we start a new medication or something, we might have to look at it within 2 weeks or 4 weeks or whatever. So that's just an overview of how to develop the components of a good goal. Be very careful with the words. I really strongly advocate that we use the word minimize instead of the word prevent. In other words, minimize the risk of injury related to the fall or a fall. Minimize the risk of triggering a resident or re-traumatizing a resident. Because when you put the word prevent in there, it's impossible. We cannot prevent falls. We all know that as staff. We cannot prevent re-traumatizing residents. There will be things that we do as staff that are going to traumatize a person. So don't put something in the care plan that is absolutely not doable. It sets us up for failure and is quite frankly a huge risk management issue. We tend to focus a lot on reducing expressions of distress. And I want to say to you that, to me, I'm going to use the word incorrect, because when we continue to focus, and like the examples I have here, reducing episodes of racial slurs, fearfulness will be reduced, complaints will be reduced, verbalizations of help me, all of these are basically expressions of distress. And even if I were to reduce those, it doesn't necessarily mean that I have addressed the underlying cause. So what I'm asking us to do here is use more of our person-centered, universal human needs. So in other words, what is the underlying need that this person is trying to have met when they are crying, when they are using racial slurs? And that's a difficult one because that can be really hurtful and offensive to many people. So, and again, it doesn't mean that we agree with the resident that does those, but if we can seek to look a little deeper and understand why and be curious and assess the symptom and then care plan the cause. So if we realize that expressions of distress are a means of communication. So what is the underlying cause of those symptoms? Is it pain? Is it trauma, loneliness, fear, confusion, delirium? And then ultimately, what is the unmet need? Is it that this person is seeking to have more comfort, safety, reassurance, predictability, trust, or is there need for movement? And then the care plan should be based on those factors, not the expressions of distress or the symptoms. Another really important part about goal development is that we emphasize desirable actions, okay? So instead of stopping the tearfulness or reducing the episodes of fill in the blank, if I were to say to you, well, what would the resident be doing instead? If they were no longer crying or using racial slurs or yelling out, help me, what would they be doing instead? So I'm asking us to shift our paradigm and our thinking. What they would be doing instead is now what the care plan goals should be focused on, helping the individual work toward meeting an unmet need, improving their quality of life. So person-centered and trauma-informed goals. Two things: increasing comfort, and I'm not just talking about physical comfort, although that's really, really important, of course. Mental, emotional, and spiritual comfort. And then ultimately our goals should be focused on minimizing suffering or reducing distress. That's where the goals should be centered around. And here we go with the universal human needs. I showed this next slide to you in the nonviolent communication slide deck. Here it is again. And again, you guys, I keep this right here on my desk at all times. Here it is. I've laminated it because I use it every day. When we think about each of us as an individual, look at all of these things here. So if it were me, I would have multiple copies of these at every care plan conference. I would carry copies of them in my clipboards, or when I go in to meet with a resident or meet with a family, I would take them to staff meetings. Because when we have distress or frustrations or irritability, there's always a connection with an unmet need. So having these things as a reminder can be a wonderful tool for all of us to expand our emotional intelligence. Okay, So these next sequences of slides are going to go rather quickly. You can print these off. You can create your own worksheets. These are all for you to use however you see fit for your community if you do want to. What I've done here is I've created what I'm calling goal starters. These are all based on the 6 principles of trauma-informed care, which, if I can remind you quickly, are safety, trust or trustworthiness and transparency, peer support, mutuality, cultural and historical issues. There's 6 of them. So what I did was I went through and tried to craft goal starters that facilities can use to then personalize, make person-centered for whatever the resident, whatever they learn about the resident. So reminder right away, increasing comfort, minimizing suffering, engaging in self-comfort and grounding strategies, express comfort to talk about trauma symptoms or triggers or feelings. Resident will participate in decision-making, identify and minimize triggers. So remember, the goals are what the resident will do, okay? What we will see different with the resident when that goal is, even if it's not met, if there's a slight improvement. So the goals are all about the resident. Here's slide 2 of 3. The resident will express feelings of being valued or acknowledged, or a sense of strength and empowerment. Will incorporate a strength and you fill it in. Develop a new skill. Here's slide 3 of 3. We'll talk about their life experience and how it impacts their current situation. Resident will verbalize feelings of hope and their potential for healing. So again, the flavor of all of these is going towards improving quality of life. It's not about decreasing something or taking away an expression of distress. Let's talk about approaches or interventions. Either word, to me, they're interchangeable. This is really, to me, where person-centered care really can come alive, because the approaches are what the staff will do to help the resident accomplish the goal, to help address, support the unmet need. These are actions that contain an action verb, and I'll give you a list in just a minute. But I want to make it clear that the approaches are what the staff will do, not just what they won't do. So again, we're trying to make it a positive action of something I can actually go in and do. Interventions should support meaningful, consistent relationships. And I put some examples here of the spirit of, oh, let's find solutions together, rather than we are the staff, we are the IDT, we know best, but more of that collaboration. So collaboration is one of the most important trauma-informed care principles. And then interventions should provide information about how the staff can address an unmet need, but also how they can continue to enhance needs that are already being met. That's really important too. So we're not just focusing on what's not being done, we're focusing on maintaining or improving what's already in place. So here's a list of interventions or approaches, and again, these are what staff will do. They're always a verb. These are just a list of some examples. I'm sure we can come up with lots more. So take a look at your care plans and see if the interventions, a lot of times I find that people struggle with the difference between goals and interventions, and I see that they're mixed up a lot of times. So the goal is about the resident, the interventions or approaches are about what the staff will do. So here are general, so notice this is general, person-centered trauma-informed care interventions. So I'm not going to read all this to you, but I put these in here as some ideas, some things that you can consider as you begin to expand your ability to create trauma-informed person-centered care plans. Here's some starting points for you, some things for you to consider. Staff interventions. Interventions for safety. So the next sequence of slides, again, I'm not going to read these to you, but they're available in this slide deck. These are interventions specific to each of the trauma-informed care principles, starting with safety. So I have several slides that just address interventions most related to the principle of safety. There's definitely overlap here, so there might be some repetition, but in general, so here's a bunch of interventions for safety, and they continue. just a couple things here. So let's say the resident has been triggered by something and they are expressing some kind of distress, either frustration, irritability, yelling out, following staff down the hallways, requiring immediate attention, things that we can do. So what is it that we could do in the moment to help that particular resident, to help bring a sense of safety and calm to their space? Things like we could say, "You're safe. I am here with you." So these are the kinds of things that I've put here, all sorts of ideas. And this third slide, so this one, we talk a little bit more about triggers, discussing triggers with the interdisciplinary team, minimize exposure to known triggers. So if you interview someone and you learn that something triggers them to cause distress in their life, that's what goes in the care plan. That's what gets shared with all the staff so we can know, hey guys, if whistling really bothers this individual because it reminds them of something horrific in their past, please be sure not to whistle around the person. Or if a particular smell or a particular phrase or whatever it might be. And the fourth slide, there's just so many that were related to safety. Safety is one of the most important. So remember, we're talking about physical safety and we're talking about emotional safety. And the fifth slide. So lots of ideas. Here's a slide with interventions for trust and transparency. So this one is really talking about how can we more clearly involve the individual into decisions affecting their care, being reliable and following through, offering information rather than waiting for the resident to ask. We're being more proactive, more transparent. Here's some more interventions for trust and transparency. And then I put a section in here. This is on boundaries. Again, another, I keep saying important, but this is also important. Boundaries are so important with trauma-informed care, and this goes for staff and residents, but I'm going to focus on residents for right now because we're talking about care planning. Sometimes when people have a history of trauma, it can be very difficult to uphold boundaries, especially if their trust has been violated, if they have been bullied or shamed or minimized in any way. So one of the most effective interventions that we might do with staff is to begin, as we create safety and trust with this person, to begin to talk about, well, what are the boundaries that you might like to establish? Perhaps it's boundaries with how they want their care provided, or a boundary with a family member or someone else. So the questions here, the last part here that I'm circling, these are questions that would help you craft interventions around boundaries, to engage in a dialogue with the individual to learn more about what they want as a boundary. Interventions for peer support and self-help. So there's several ideas here. Remembering peer support as a principle of trauma-informed care is when the peer support is when we've all shared a similar experience. And I'm going to use the pandemic here. So there's a sense of camaraderie and peer support because we all have a sense of what it's been like to live and work through a pandemic. So with residents, how can we help develop peer support with the residents in your community? Meaningful engagement. Interventions for collaboration and mutuality. And interventions for empowerment, voice and choice. Again, lots of ideas here. And finally, we have a couple slides, interventions for cultural, historical, and gender issues. All right, second slide with that. This slide I wanted to include, now one of the next videos that I'll be recording is going to be talking specifically about grief and mourning. Because we're talking about care plans here, and this is the intervention section, I wanted to at least bring this into our discussion. There are many interventions around grief. And I think that in this very tender time with the pandemic and all the loss and the heartache and the stress that we've all been through and going through, including residents, here are some things that if we can, as staff, learn how to do these things, that we are doing these things and we're in the care plans, I think it could really do wonders in terms of recovery and healing and growth. So when someone is in a state of grief or mourning, sitting quietly with them, Focusing on listening and not trying to problem solve. Acknowledging, this is so hard. I hear you. I'm right here with you. And then silence. The power of silence when someone is in a state of grief or mourning is very, very, I call it the essence of presence, of just being present with someone, allowing for tears. If they wish to talk about it, listen attentively. You can ask questions like, I love this one. Does the grief feel like a wave, like it comes and goes? Are the waves big crashing waves, or are they just kind of like this, undulations? So begin to just allow the person to be present with them and their grief. And then ultimately, when you look at the care plan, if there was a new nurse, an aide, a new staff member, a new social worker, anyone, would the care plan be helpful? Would staff know what to do? And ultimately, does that care plan document instill warmth or negativity? So that's kind of, to me, the gold standard here of developing a person-centered, trauma-informed care plan. In closing, I just want to remind us that, one of the most important, again, elements of care planning is that the care plan interventions are consistently applied across all shifts, all days, all shifts. So this really speaks to process improvement. If the day shift puts a care plan intervention, perhaps they've learned about a particular trigger for a resident. How do we make sure that that information is shared with the evening, the night shift, the weekend staff? So consistently applied across all shifts. And as I've done in all the other video series, what are your action steps? By next Monday, do you have some ideas of what you might do, or whatever day of the week works for you? Or I will share this information with. So we continue to maintain momentum as we all grow in our capacity for trauma-informed and person-centered care plans. Thank you so much for your time, for being with me for this video. As I mentioned earlier, this is the Dementia-Friendly Empathy Worksheet. I know this is a bit small font. This document is also housed on the video training webinar webpage. My bio is here. And just to, again, Barbara and I give our sincerest gratitude to the Care Compass Network and Finger Lakes Geriatric Education Center for making this video series possible. Thanks, everyone. See you on the next video.